right, excellent. We'll officially get started in just a few minutes as people are kind of logging on and piling in. In the meantime, so glad, so privileged, and so fun.
Shucks.
Yeah, it's exciting to have Dr. Graham Walker back here on tour, right? The one was not enough. I first met Dr. Walker when I was an intern, I think,
and I was a med student.
Yeah, and I was like rotating through the emergency room, and here's some random emergency doctor correcting me all the stupid stuff I was doing. And we were chatting a bit. It's like, wait a minute, you do this, you do that?
Oh, we had a computer handshake, I think. Yeah.
Oh, cool. You know, when you find these kindred spirits, it's a very unique thing. Most doctors are not so kindred in some of these ways, which I think we'll talk about. But very famous for basically creating the MDCalc system, which essentially every doctor in the world uses, probably not even realizing where it comes from. But actually, we're not going to talk about that, I don't think, because the world's moved on. You move on to even bigger and better things. So tell us a little bit. Well, I think I'm going to get into your actual talk in a bit. Before we do that, just tell us about yourself. Where did you grow up? How'd you arrive doing what you're doing?
I'm from Kansas City, from the burbs of Kansas City, Missouri, but I live on the Kansas side. Went to Northwestern for undergrad and studied social policy, which certainly like influences the way I still see the world. And then went to med school here. Most importantly, met Jonathan, and then did residency in New York City in emergency medicine. Came back here, did a sim fellowship. So I was here back at Stanford for a year doing simulation medicine in the ER here, and then have been at the Permanente Medical Group, which is the med group for Kaiser Northern California. I've been there since 2012 at Kaiser San Francisco. I live up in the city, and I've had a bunch of different roles there. Currently, I run advanced development and kind of AI tech transformation for Northern California.
How long have you been doing that one? Is that like a recent or you were already?
About a year and a half, officially like a year.
Did this position even exist 2 years ago?
No, it didn't exist. We have a new CEO who's a cardiologist who's brilliant and super aware that like medicine needs to get with the times. The world's changed, and we never had a chief innovation officer, so I sit right under our chief innovation officer and figuring out how we can bring not just AI stuff, but just like more technology. Our patients want it, our physicians and our NPP providers are burning out and quitting, and so how can we like make things better? Often with kind of ideas around AI, like the entire world is talking about, of course, but it doesn't have to be. Just anything that's innovative and moves the meat, as we say in the ER.
Do they come looking for you when they're creating this, or they like advertise the position? You say, "Hey, actually, I want to get in here." Or
I knew our now CEO, Dr. Maria Ansari, used to be my direct boss at the Kaiser San Francisco Medical Center. So she and I have worked together for a long time and thought, hey, this would be a perfect
somebody who's
opportunity. Yes, and it's like it is a dream job. It's like I'm about half-time clinical, so I still work nights and weekends and day shifts and swing shifts in the ER, and then my other half-time is AI stuff and getting to talk to people and talk about what TPMG is doing. We're hiring, just like get to like connect people and network and help our doctors take better care of our patients.
To be loosely, you're hiring doctors, you're hiring people who are not doctors who can make a difference here too.
We are hiring mostly doctors, but certainly like informaticists are going to be an increasing presence, I think, in all of healthcare. And like the data is growing exponentially, and certainly the physicians, even like I'm a clinical informaticist like you, but even the clinical informaticists are still like, at least at TPMG, we're all like at least half-time clinical. So a lot more work to be done when we're off seeing patients and stuff like that.
Awesome, fantastic. I certainly rediscovered Graham a little bit in the past couple years with the world changing. You have a very big LinkedIn, at least personally, that's why I'm reading you a lot. And having a lot to say in the field because there is a lot to kind of cover and have a very thoughtful voice and very engaged. I thought let's get Graham back here because we have a lot more to talk about.
Yeah, thanks.
Please take it away and happy to drive the discussion.
Thanks for having me. So this is probably going to be like the least informatics. Well, maybe it won't. Maybe it will be an informatics-ish topic, but I'm going to talk to you guys about like I hate to like call it not sexy stuff because it is really important, but it's stuff that's not about like we're going to be talking about like data tables. So we're going to be talking about like normalizing your data. I'm going to tell you about all of the challenges to getting AI technology, like really any change developed and rolled out and deployed in healthcare. And what I've learned from those changes. And if there are any budding entrepreneurs, like there do tend to be in Silicon Valley, like I will maybe give you some tips on things that you could like add to your feature set that your competitors will not have, because these are problems that are not like, again, super sexy, exciting topics. So I'm gonna be super practical. That's certainly my bias as an ER doctor. We keep it super simple because we literally cannot keep up with the rest of it. So I'm using this, we'll see if this works. I'm using this platform called Gamma. It's an AI, I think what they're doing behind the scenes is they're like taking ChatGPT and then they're having it program some custom HTML code to make a PowerPoint. And I thought it'd be fun to try this out for this. I'm not sponsored by Gamma. In fact, I'll tell you the product didn't work very well, but I will continue using it for a couple of important reasons. Okay, so I asked it just, what you can do with this Gamma thing, and there's a couple other competitors I'm gonna try too, is you just tell it what you want on the slide and then it just makes it. It does, you know, I gave a little blurb about myself and that's what it represented as me. That's just an AI generated generic doctor. I don't think I'm that handsome either, so here is like here is the prompt. I mean, this is literally this tool. So I thought it was really interesting. You just give it a prompt and then you can like say the type of template that you want. You can have it pick for you. And then you can do like your standard like template deck with like a picture on one side or 2 rows of bullets or whatever. And it'll just do all the work for you. Now I will tell you, this thing was terrible. It did not do a good job of coming up with this presentation for me. So I like took the time to try to give it like a really clear, like bullet by bullet thing of what I wanted each slide to say. So I kind of had to redo this entire deck myself, but I really like the UI. If you guys use Notion or Slack or anything like that, you can do like slash commands. So you can do like slash bullets and it'll make a new bullet thing for formatting and stuff like that. So I actually really liked the UI. It's you know, you can have it do AI generated images. You can have it do essentially a Google image search and then just insert that image into your PowerPoint. So you don't have to do the copy paste thing. You can upload images. You can, I barely scratched the surface. You can embed YouTube in this. So I don't know, I thought it was a cool thing and I figured why not? Give it a try at this informatics and AI talk. So I'm gonna talk a little bit about our experience at TPMG deploying ambient AI. This was a paper from the New England Journal Catalyst, which is like a pretty practical journal, kind of offshoot of the New England Journal, focusing on kind of healthcare operations and kind of deploying tech and deploying workflows at health systems and hospitals. So this came out about a year ago. I was not involved in the direct deployment of this, but I do sit on our clinical informatics steering committee for our EHR. We use Epic. We call it KP Health Connect though, because we like to have our own terms for literally everything in our organization. But I'm going to tell you about a lot of the hurdles that we ran into as we were deploying this. Just in full disclosure, we at the time when we published this, we were using a tool called Nabla, which is a great generative AI scribe technology tool. We've since switched to a Bridge, which is another generative AI scribe tool. If you're not familiar with these, the idea is, I'm your doctor, I get consent from the patient, I say, hey, would you mind if I record this conversation? It helps me write my note for me. Most times the patient says yes. I take my phone out, I put it in front of the patient, I hit record. Literally, that's all I do. And I just talk to the patient. Oh, you're having knee pain, tell me about it. I take a history, I can examine the patient. And what is it doing? Oh, it's just like recording it, probably running it through Whisper, you know, to translate it into actual text. And then it's running it through an LLM to summarize that text. And then it's outputting in kind of a templated physician level note format what comes out. So all I do is when I'm done, I say, oh, thank you so much. It's great to meet you, which I definitely say all the time. I hit stop, I walk back to my desk, and by the time I'm back at my desk, back on the desktop platform, or sometimes even integrated into the EHR, my note has been written. Now, is it a perfect note? Of course not. It's generative AI. We know that there are lots of challenges with this. But my note is, I would say our physicians are about like 90% happy with the notes. And that's some mixture of like 90% of the time it's perfect, and then some mixture of 90% of the time they have to change, 5 or 10% of it. It is, I think, better than dictation. Dictation does struggle with mumbling that I sometimes do, or loud sounds, like when I work in the ER, or saying can versus can't, which obviously in medicine, it is critically important that you get like positives and negatives correct. So I do think it's very good at that. It is done, these tools are remarkably good at like separating out voices. You could have 2 screaming children in the room, one with listening to an iPad, the other is the mom or the dad trying to talk about the parent or about the kid, and it still is able to do that pretty well. It's also pretty good at deciding, making a decision whether parts of the history are relevant to the note or not. If Ron comes to see me in the ER and says, oh, I ate a hot dog at the Giants game and then I started vomiting, it's going to include that in the history of President illness. If Ron just says, oh yeah, last night I was at the Giants game, it's probably going to remove that entirely. It might include it in like the social history. Oh, the patient likes going to baseball games, whatever. So these tools are pretty good, but I would say ours was probably the first and maybe the largest deployment. And now I think these are relatively common, especially in larger medical centers as well. So again, I'm going to tell you stuff that is like, this is real work that is done, I promise you. And then stuff that I think actually, if you build in some features that help address these issues, not only will you like make doctors and administrators and the CFO happy because you're building tools that work better for their health system, but your competitors, if you're building something, may not be thinking about these things because they're not super exciting, amazing stuff. So please stop me, ask questions. If I just run through my slides, it's going to be a short talk. And then the last thing I'll say, I was thinking about this on the drive down here. So most of what I do as an ER doctor is I don't solve problems, I manage dilemmas. And the fact that I'm an emergency doctor and I do not, most of the time, cure things, resolve things, take things to completion. I will treat symptoms, I will manage things, but even an ER doctor, most of what I do is management of chronic disease. Someone forgets to take their diuretic pill, and so they get short of breath, or they take too much diuretic pill and they get dizzy. So much of even emergency care is managing chronic disease of our aging population. And when you're managing stuff, you're actually not solving the problem, you're just dealing with it. I wouldn't say kicking the can down the road, but like, if I like suture up a laceration, I consider that something I fixed, right? If I take somebody that's like puking from norovirus and they're like feeling better, and they're tolerating some fluids and I'm able to discharge them, yeah, I consider that a successful management of their problem. But honestly, you guys, like 80% of the patients I see are elderly diabetics with numerous medical problems, and one of those medical problems or multiple of them have kind of gotten out of whack. That plate that they're spinning has kind of started to wobble, and it's my job to re-spin it for them. And in the same way, a lot of informatics is a lot of the problems or a lot of the dilemmas I'm going to show you here are truly dilemmas. There's not actually a solution to these. There's just different ways of managing these challenges that I'll tell you about here. So if you can't see that, so I'm going to kind of run through as many of these as I can. There are challenges with training. There are challenges with support is a nightmare. We will talk about feature requests, analytics. Do you want to integrate with an EHR, IT infrastructure, policy, regulatory compliance stuff, and then just like money is on everyone's mind, especially these days as healthcare is certainly struggling. Most physicians probably have never used ChatGPT. That might sound crazy to all of us in this room in particular, where I use it multiple times a day. I use multiple LLMs I freaking used the freaking LLM to make this presentation. And it didn't work very well. But most physicians, I bet you, do not have a ChatGPT account because most physicians are just like normal average humans who decided to go to med school and residency. So like I am always amazed living in San Francisco, the minority of the doctors that I work with have used ChatGPT before. Now that's starting to change. We have access to Microsoft Copilot, which is kind of like ChatGPT, but like a neutered version of it. But most physicians don't know really much about AI, and that could be generative AI, that could be predictive AI. I have done, I gave a lecture to all 10,000 of my physicians last year about AI. I'm giving another one in 3 weeks because this is going to take a lot of information for physicians to understand, not necessarily how this stuff works, but how it can fail, how it can succeed. And it usually is easier to tie it back to a medical concept because that's easier for doctors to understand. So typically doctors will talk about sensitivity and specificity. You know, if somebody comes to the ER with right lower quadrant pain and vomiting, they may have appendicitis. I will often get a CAT scan on that person, but a CAT scan is not a perfect tool. About 3 to 5% of the time, the CAT scan is incorrect. They have a false negative CAT scan. They actually do have appendicitis. And so describing these in terms that physicians can understand in the way that tests work or side effects of medications, I think can be really, really helpful. So that's the education piece, similar to the knowledge gap piece, and then just the onboarding. Doctors, most of your physicians that you see or that you work with, most of us have clinician jobs. We see like 20 to 30 patients every single day. So when do you onboard these people? Say you want to give them a new tool, or even just a new workflow. Say you have a different way of managing appendicitis in the ER or chest pain in the ER, one of the most common things that I see. How do you teach or educate somebody on how to change their workflow? We are busy people. And so this is what I mean by dilemma. There's not a right answer here, right? There's lots of, we can go around the room and all come up with different ways you could do this, right? Well, you could pay doctors to come early. You could do it during their doctor's work hour, but then they'll just maybe see a few less patients that day. You could do it during their lunch hour, but maybe, honestly, that's probably when they're documenting and writing their notes and catching up on labs that they're behind on. So there are not solutions to these problems, but this is just acknowledging that these are dilemmas, helps you to understand there's actually not a right answer here. If you come up with a magical new AI tool and want to sell it to a health system, going into this knowing that acknowledging that onboarding is going to be a challenge and being flexible with the health system about how they want to do that, I think can be really helpful. Okay, so this is just a small number of questions that I have personally been asked, not just about AI tools, but literally workflow, a new iPhone app. My phone app isn't working. My phone won't connect to Wi-Fi. In my previous role within our medical group, I was kind of in charge of tech operations, called it Assistant Physician in Chief for technology at my hospital. So anything tech related, every single doctor knew to come to me. Whether it was support, questions, concerns, features. So all of this stuff will come up when you're trying to deploy, certainly AI, but really anything. What does it do? How does it work? Does it actually work in my specialty? Oh, I heard about this. I heard that like the OB-GYN doctors were using it, but like, can I use it? The OB-GYNs love it. Does it work for me? Or is it like, oh, if it's only given to the OB-GYNs, well, why can't I have it? Was it tested? Do I need to get consent? And then is this being recorded? So based on the type of tool, some of them will record it so that you can actually go back and look at the source information. Others, again, back to dilemmas, others have chosen to not record that data for medical legal reasons, and they actually just delete it off their servers once it's transcribed. So there's actually no more record of what was actually said. Again, some doctors like that. Other doctors think that's a terrible idea. Is this saved? And then, of course, anytime anything is deployed in healthcare, can I get sued is going to be a question. And then, certainly you guys here at Stanford, certainly me up in San Francisco. Literally everybody somehow lives next door to somebody that has deployed or created their own LLM generative AI tool. And so there are always 1,000 questions. Well, why did we choose to use this one, not that one? And that's obviously way more complex of a question that I or anybody can answer. Okay, so we talked a little bit about user onboarding and training. I'll talk a little bit about tech support challenges because that was my role for 6 years, and it is extremely hard to support physicians. And I say physicians, but it's nurses and pharmacists and social workers and everybody. And then I'll talk about bug reporting and features as well. Okay, so here are just a few tech support challenges. These are all common questions. Like I went to Stanford with Jonathan, like I thought all doctors were really good with technology. Like I was fixing my friends' printers and whatever. And then it was not until med school I realized like, oh, actually, a lot of doctors really suck at technology. Like they're really bad at it. And they're in that way, they're very much like everybody else. And we're the oddballs that actually know how to use a password manager. So like all of these questions get asked by doctors and nurses during a shift. Say you went out on vacation for 2 weeks, you come back, oh, now I can't access my system. Well, what is the doctor going to do about that? And then one of the common questions is like, how do I actually even report a bug or a problem? And I will tell you right now, if you are lucky, you will hear about like 5 to 10% of the actual bugs that your users encounter in healthcare. We do not have time to, again, remember, every 15 to 20 minutes, a doctor is seeing a new patient. I saw somebody on, I think, TikTok or somebody say like, practicing medicine is like having a new sit-down meeting every 20 minutes with a new person, but you can't remember or you don't agree on the agenda, and you have to have everything completed within that 20 minutes. Otherwise, all the other people behind you are gonna get pissed. So most of the time, most doctors that have problems, I never heard a peep of them because they didn't have time to report it or they didn't know how to. You guys have called IT before. IT wants to create a ticket, wants a screenshot, wants to know your user ID, wants to know what version of Windows you're on, what browser you're using. That is 5 minutes that physicians simply do not have.
And this comes up often, right? Doctors are too busy, the 15-minute
Yeah.
visit problem. Every clinician agrees that's a problem. Why doesn't anybody say something about it?
Graham just said it right now. The guy on TikTok, I said it. Like,
Like, senior leadership, there's always buy this product, do this tech sucks, but never can we have 30-minute meetings.
Yeah,
Like no service line proactively says this 15-minute treadmill is killing us.
Yeah.
They'll curse about it, but they won't complain about it.
Yeah, I think the more physician and really clinician leadership that we have that discusses like the downsides to this, right? I mean, even if you have a patient where everything goes right and there's no bugs to report, you can imagine an 80-year-old or a 90-year-old or a 100-year-old who are not uncommon patients that we see anymore, who has 30 medical problems and takes 30 medications. A 15-minute appointment will not really help that person. You can address 1 or 2, maybe the biggest problems that they're having, but trying to rush through. I mean, have you guys ever talked to a 90-year-old or a 100-year-old? It's incredible. I mean, really, it is incredible what they have seen in their lives, but it is, you can't rush them through an evaluation. It just does not work that way. So I totally agree with you, Nick. It's a big problem.
Yeah, so I think the root cause is something else and we're kind of plastering it over with random nonsense technology.
Incentives, yeah.
Yeah, why don't you pay a couple $100 for every bug that you report?
Well, I mean, there's your incentive right there. Like if you incentivize the bug reporting, yeah.
well, that leads to, I got $100 I can make a plan right now.
That'll be a bounty for the best competition.
The Blues Creative Death Book, yeah,
It
Ron.
was something that I feel like maybe people who in IT or folks who are kind of responsible for managing bugs may not actually recognize. Texting, like more kind of the elbow to elbow engagement is actually much more effective. So I actually remember I was on service on the weekend and there was something wrong with the you know how to do like kind of the verification of opioids and prescribe it. So that wasn't working. So I literally could not discharge a patient on opioids. And I had to get it fixed. And then ended up getting fixed, but I remember with the person I talked to, they're like, oh, let's schedule a 30-minute meeting, you know, at 2 p.m. later today to like troubleshoot. And I'm like, I'm not doing that. But you can call me and then we can figure it out. And then we ended up doing that. And then the issue got resolved, you know, in like 10 minutes, but it was a larger issue. So I think a lot of stages like this, even the act of scheduling meetings is just such a foreign and maybe it's just the concept that doesn't align well versus if you just happen to know that person, you text them and you do a quick call, like often that issue can be resolved much more quickly in my experience.
Yeah, I think, you know, as a shift worker as well, if you call something in on the night shift, somebody's gonna try to call you. I mean, I know to like have my phone off, not even on silent, because they have the ticket, they have my phone number, they are trying to fix my problem, but I'm sleeping. It's like 10 a.m. Like, please don't wake me up. I have another night shift to go to tomorrow or tonight. So it's a real problem. Yeah. We, you know, when I ran technology for Kaiser San Francisco, we started right before COVID. Unfortunately, we started this thing called in-person rounding. And so it was, you know, just like you round in the hospital, right, with your team of people and you check on all your patients. We did in-person rounding with me, my kind of IT leader counterpart, someone from site support who can kind of fix Epic problems, someone from kind of more like the hardware side of our organization that can like run cable and reroute Ethernet stuff. We had a training person as well, because that was part of the issue too. And then we had a project manager. There were like 6 of us. We would literally just tell the department, hey, Department of Nephrology, we're coming to your department Tuesday at 2 p.m. If you have any tech issues, we will be there. And if you have any questions at all, we will just show up and answer your questions. If you need a ticket filed for something that's low priority, we'll file a ticket for you, right? It absolutely makes a difference to just have people physically there. And then you also make that relationship with the person. So in the future, they know, oh, I can email Graham about this or something. Yeah. The other challenge here, the other bug slide, is a couple things. This is a lot of stuff on this one slide, but so everybody knows this concept of it's not a feature, it's a bug. And I'll get to that in a second, but we have 10,000 physicians in Northern California. Even if you say like, okay, most bugs don't get reported, even if you like said, oh, there's a bug a day, and you tried, all 10,000 of our physicians were trying to do their best to report a bug to one of our vendors, one of our AI partners that we work with, we would decimate them. I mean, 10,000 doctors seeing 20 patients a day, that's like 200,000 patients every single day in our health system that we are seeing. And like imagine there's 1% of those encounters or 0.1% have a bug, and that's every single day. Like that would decimate any tech support system that's not, you know, that especially something that's like a smaller, you know, Series A, Series B company. They don't have the capacity for that. So you have to come up with a way to report your bugs internally to somebody inside your system who can then collate them, see if they really are bugs, and then take that information and get it back to the support people to solve the actual problem. This breakdown I have found to be true in every clinical informatics complaint list I have ever seen. I've sat on our EHR steering committee for almost a decade now. I'm in charge of emergency care and urgent care for all of Northern California. And there's kind of 4 ways that what the end user tells you is a bug actually is. Number 1, it's actually a problem with your internal system. So Stanford IT or Stanford Informatics or Jonathan decided to do things a certain way. And because they decided to do things this way, it created this new problem, and it's not something that the vendor can fix, because it's a decision. You decided to make it so that like visitors can't log on to the business Wi-Fi. There's a really good reasons for that, for security reasons, but those are gonna create other downstream consequences. It's not actually a bug or a problem at all. Number two, these bugs are actually features, but just they were built in different ways for different specialties. So I might, maybe the founder of this company is an ER doctor, so they build tools that are really good for emergency medicine, but they suck for orthopedics or for pathology or for cardiology. And so, if you have a cardiologist saying, hey, get rid of this, it's terrible. Now you have two doctors arguing about, but the ER doctor says they love it. And so how is the vendor supposed to decide who's right? Now they can start to add features and customization and make their settings list longer, but it's actually, sometimes, again, it's just a dilemma. And then there's also a problem where this is extremely common. It's actually not a bug. You actually can do that today, but people just didn't get onboarded, they didn't get educated, or they did, but they forgot. I would say at least a quarter of the complaints that I received are actually like, oh, you actually can do that today. It doesn't require a ticket. You don't have to add new features. You just don't know how to do that feature. And then a quarter of them are actually bugs. They're actually problems that somebody can troubleshoot and fix.
So this is a super important point, and on our campus, again, very often ignored, that if you want to work with biohazard agents, you have to undergo training before anybody lets you close to a PSL3 lab.
Sure, yeah.
But we'll give people with zero training in computer science or statistics access to our entire research data warehouse.
Yeah.
And similar things on the operational side as well, like there's no expectation of minimum competence. And that's nothing to do about the user or the IT system, is that we're just expecting, Mac and Windows to talk without ever having to figure out a protocol. So what are your thoughts on, I think these are systemic issues that manifest as blowback on IT for the most part.
I totally agree. I think it comes back to like those dilemmas. Like I know the people in my med center who are particularly not tech savvy and who I typically would hear from the most. And you find ways of trying to give them extra support. In our organization, we have this group called the Department Tech Leaders, DTLs. And in every single department, in every single medical center, there is one physician who gets the download direct from the IT gods above that says what's going on at the med center, and they're kind of the person that can be elbow to elbow and help the people who are particularly challenged with kind of the IT stuff, because we recognize it's easier to hear from physician to physician, like that collegiality thing, and then there's stuff that there's stuff that comes down regionally. Right, that our entire region of Northern California is going to do this. There's stuff that we do locally in San Francisco. Hey, San Francisco is going to use this new technology that other people aren't going to use yet. And so there's kind of you kind of have two different bosses. And then there's also regulatory stuff that comes down from the gods of Sacramento and of Washington, DC that also changes everything for us too. Okay, so I mentioned this, but we all do different things, and we have different priorities, and the challenge is trying to figure out who actually should get their feature built. So one of the things, I talk about this a lot on LinkedIn, but it's always a vast oversimplification if you just say, oh, doctors do this or doctors like this. Besides the fact that we all went to med school and we all did a residency, we do really different stuff. What I do as an ER doctor, a cardiologist probably couldn't do. I certainly couldn't do what a neonatal intensive care unit doctor could do. How we spend our days, whether it's seeing patients or doing procedures or a little bit of both, is dramatically different between two specialties. And so the idea of doctors tend to prefer this type of technology, that gets you a little bit of the way, but it's a broad oversimplification. So it often tends to be easier to to go by specialty and then also go by tech savviness as well. I will fully admit on this recorded call that I don't use my AI scribe all the time in the ER because I'm like a super nerd. I have spent so much time getting my Epic health and my Epic like note templates to be so perfect. I can like bang through notes like super fast for many chief complaints in the ER. So you might think that like I'm the perfect person to adopt this new AI scribe technology. I'm literally using ChatGPT every day, but for me, it's not as useful. I'm not getting as much benefit from it because I'm either dictating or I'm typing really fast, or I've built a ton of smart lists that make it really easy for me to pick exactly what I want to say in my note super quickly. But the people that are particularly using this technology are often people who are like not tech savvy at all. So so you're actually taking people who are pretty low on the tech comfort scale, and they're often like leapfrogging over other groups of people because they're able to literally just take out their phone, they can hit a button, it starts recording, and then they just hit stop, and then voila, through the magic of the cloud, it's now on my desktop. So don't necessarily assume that you'll have the most success with tech savvy users, but also don't assume that like it's the least tech savvy that will not use your product. I have numerous stories of physicians I know who have saved, not exaggerating, 2 to 3 hours every single night. So just imagine, these people are fantastic, dedicated, incredible physicians, but they really struggle with the technology side of using the EHRs and getting through their notes, getting through all the results to get through. And so what do? I mean, we jokingly call it pajama time. These people go home, they maybe like cook meals for their kids, maybe see their spouse, maybe put their kids to bed, and then they open up their work laptop that they've lugged home with them, and they start charting for 2 hours every single night. So imagine giving a human being, imagine if you got 10 hours of extra time in your life every single week. That is transformative to your like health and well-being. And imagine like we have people that, there is data to see like people logging into Epic late at night, and then there's data showing like, hey, at 5:30 p.m. person's done with their day. Like that's imagine like 10 hours of free time every single. How many Netflix shows could you binge based on that? Incredible. I'll keep going here. Please stop me if you have questions. I like to talk a lot about evidence-based medicine. One of the tenets of evidence-based medicine is when you're doing a clinical trial, you're not allowed to change your outcome afterwards. It's kind of cheating. We think in medicine like, okay, I need to think really long and hard about like, what's the outcome that matters to me? Because if I change my mind later, well, I kind of cheated that, and I'm not really sure that the drug works as well as I think it does, or the procedure is as effective. That is not true in this space, especially with this technology being so new. It is totally fine to change your mind. This is not a clinical trial. This is trying to deploy technology. And you may even think like, this thing will be really easy to measure, so we'll use that. And then you, like 2 months later, you're like, oh, we're not getting any data about that. So it's really, it's fine to change your mind about what you consider success. And then as always, you always need quantitative data, which often like tech companies and stuff has plenty of tech data about usage and analytics and everything like that. But you also always need to face validate it, right? So if you're seeing like that cardiology is using your new tool and there's huge adoption, but then you talk to like your friends who are cardiologists and they're like, what are you talking about? What tool? Clearly there's a problem there. And maybe it's like that, like there's this big group of cardiology nurse practitioners who are using it, but the cardiologists actually never got trained on it or don't know about it. So you always need that qualitative piece. And it's often the qualitative piece that will convince other doctors to start using the thing. So I cannot convince a physician to use a tool based on 70% uptick in your department. People could care less about that. But if I tell them, hey, did you know that your colleague saved 2 hours a night by using this technology? Or you get a testimonial from one of their colleagues and get a nice quote that shows what they've actually done using the technology or how it's made their day better or why they like it. That's actually how you like drive behavior and change stuff for physicians. Yeah, Rob.
Yeah, no, I mean, I love this. I'd love to get your thoughts on kind of how you operationalize this in an actual pilot, especially kind of going back to your analogy of managing a dilemma versus solving a problem. Like, I think that resonates so well with clinical medicine because, you know, if I'm, say, taking care of a patient with an AKI, my goal isn't to cure their chronic kidney disease, it's just get their creatinine down. I mean, I admit it, like that's creatinine discharge them. So that I didn't solve the problem, but I am managing with a real, but there is a kind of a protocol for defining success for hospitalization, which is like I resolved their AKI, their creatinine's down, they resumed their home meds, like that's success. I feel like when deploying and testing technology, we kind of have that, but not really, because the mindset is like, hey, did this reduce length of stay? Like, did this? And I mean, you kind of have some of this here, but I wonder, like, how would you operationalize that? More like the learning cycle aspect of technology deployment, what metrics you use, and how do you communicate that to leadership so they understand that's what you're doing?
Yeah, you know, when we decided to deploy this technology, we actually didn't follow this. We didn't know what success was going to be. And this is again the vision and leadership of our CEO, who I mean, I would open a dizziness clinic for her. She's so incredible. But that's really bad for an ER doctor. So we didn't know what was going to happen, but we knew, like, she kind of knew we needed to do something and we needed to like take a big swing. And so we thought, because we had this, like, we have a really big technology structure, and we've got, you know, like, she also really believes in building your bench. So we've got like dozens of really good technology leaders who are physicians in our organization. We said, like, okay, let's try a pilot with like 50 or 100 people. I think we focused on primary care because we knew primary care in particular was suffering with pajama time and everything like that. We saw really good signs with primary care, and we said, I mean, you know, it was a little bit of like stepping off the cliff and hoping that you're going to fly or something, because we didn't know, but we had good early signs. And you know, we have a lot of experience deploying technology. It's different every time, and all the challenges are different every time. But like, you know, I think in 2014, we gave all of our doctors iPhones. Imagine trying to do that for 10,000 doctors. And like, you know, you guys probably have to do this too with like e-prescribing. Like, you guys have to like do the login to your app to do 2-factor authentication because it's secured, you know, it's a controlled substance. Like, that's a lot of work to figure out how do you reach doctors that only work night shifts? How do you deal with anesthesia? How do you deal with people who only work in the dialysis center? Like, I think it's certainly a tribute to like having a structure and having a network of physicians who know how to talk to each other and support each other. I mean, I'll also just call out like that is also paid time those physicians get. It's not a lot of paid time, but like it is some acknowledgement of like, okay, if you're gonna try to be responsible for IT for your entire department, like, oh, there's one cardiologist responsible for training all 40 cardiologists about Cupid if we're deploying this new Epic module. Like, you give that person some time every month to do that. Yeah.
Can you reflect a little bit on the safety of this and like
Sure.
when you're saying like not like a clinical trial, is this mainly for, like, has it gone through like progress kind of?
Oh, of course, yeah.
Panel?
Yeah, great question.
Okay.
Yeah, so there's obviously risk involved in any new technology or any new drug, or I mean, in that way, it's been kind of nice because we have in healthcare, we have structures and know how to think about risk and benefit. I think a little bit, you imagine if this was like in marketing or something, marketing probably doesn't think about risk as much as medicine does. So we have structures to think about that, and then we, you know, spend a lot of time. I said, Ron, like in small pilots, see where these things work, see where they don't work. And I think that's like a lot of the, I think that's what we're starting to see in the literature, that like there are areas where these tools work really well. And then at least from what I've seen so far, like there are areas where they kind of suck, like not very good in pediatrics. There's a paper a couple months ago that like, it's not very good in anesthesia, coming up with anesthesia plans, because those are pretty like nuanced different than like, oh, hi, I'm a doctor, you're a patient, you know. So yeah, there's absolutely risk there. I mean, you know, same with all the LLM technologies, same with the automated response technology from Epic and using large language models. And I think it's kind of a new frontier that we're all trying to figure out, like, how risky is too risky? What does safe even mean? I cannot tell you the number of strange cases that have shown up to the ER that I never would have predicted were things that could happen to human beings. And so it's like, we will never be able to fully say that this tool works perfectly, especially because like, oh, great, 4.0 was good. Well, they just trained a new version of 4.0. So now do we need to retest this? How do we come up with all that? I mean, it's a challenge for sure.
Can I ask a question?
Yeah, of course,
based on
yeah.
that? So like when you get, for example, like one of these models, and will it change when it's updated? And the reason why I ask this is you also change the way that you speak to a model when it's updated too, especially for these larger ones, and are clinicians changing their behavior actively?
Yeah, you know, even more on the predictive side, like I've imagined like, okay, we came up with a really good predictive risk score that said, oh, we should put more patients on blood thinners. Well, then if like the GI guys have like a GI bleeding risk score for them, that's gonna screw up the first one. So like there's gonna be weird interplays that like it's a brave new world that I don't think any of us really know how to handle or what's actually gonna happen. I mean, I'd love it to all just work, but I don't think any of us in this room would probably have a job. Oh, work, it just works.
So, yeah, this problem that was just brought up, the intersection of the multiple pockets or puddles of technology, as I like to call them. Because, you know, everybody likes to think of healthcare as a system and doctors as a single species, but, you know, we have 123 medical specialties on this campus. You had a question up there.
Yeah, it was like, there's more than 50 probably, but yeah, that's crazy.
123 residency and fellowship programs, if you count each one as a specialty. There's 184 professional medical societies in the United States, 13 just in cardiology. So we have this massive fragmentation, like everybody is experimenting in their own puddle. How much, like in your sort of gestalt opinion, how much of that experimentation is just chasing the hype cycle versus actually trying to make a difference?
I think they're all trying to make a difference. I think the challenge is, that's why I'm talking to you about this stuff. This is the stuff that you have to do in order to get your stuff in front of, like, to production, like in front of users. It's all this stuff that's like, has nothing to do with informatics at all, or like an F1 score. This is just like, how do I get this thing in front of the person and have them actually use it? How do I get it deployed? How do I pay for it?
But even before that,
Yeah.
should we even do all this labor? Because often, you know, going back to that 15-minute example,
Yeah.
the root cause is something else.
Sure. Yeah.
And then we're just piling on labor without having a conversation about the root cause. And when we have this massive systemic stampede towards AI across all of our specialties, we might end up doing more harm than good.
I think it's, the sense I get is that people are trying to like fix things within their control or their sphere of influence, like that concept, right? Like we can't go to CMS and change the regulations, and we can't, you know, just to our whim. And so it's like, oh, well, this is the stuff that I can control. You know, I struggle with that a lot. And it's like, how much of this is worthy experimentation and we have to figure this technology out? And so let's all publish and talk about it a lot. And then hopefully we'll like somehow like extract like the really good stuff. And how much is like, no, it's just gonna sit on a PDF server somewhere and not actually not go anywhere. Yeah, I don't know.
So what would you tell the trainees? How should they prioritize?
That's a great question. I would probably say, that's such a good question. I would probably say focus on, like, find a clinician partner and help solve their problems and really understand the problem. And I think to your point, like, understand the root problem, not the more superficial, like, oh, can you click this button for me? But, oh, like, why is there a button? Like, can we make it not a button? You know, I'm sure there'll be, I mean, it'll take a while in healthcare, but like, there'll be some agentic AI stuff that will get rid of the button, but there's a great, what's the University of Hawaii or Pacific article, kill the stupid stuff.
University of Hawaii.
Yeah, it's a great paper,
Get
essentially.
rid of the stupid stuff or something like that.
Yeah, no, gross, yeah, get rid of stupid stuff. And the idea is, if you guys look into our EHRs, I'm sure ours and probably yours too, the number of flow sheet rows is just incredible. And it also changes every January 1st because Sacramento has a bunch of new things that have to get documented as well. So this paper essentially said, asked every person that logged into the EHR, hey, is there anything you actually don't need to do? Like, could we get rid of anything? They had a bunch of ideas, they had a committee, they formed it, and they actually went through and deleted a bunch of crap from the EHR and made everybody happier. And then, you can actually, if you do the math and you have a big enough system, if you have 500 nurses and 365 days of patients and the nurses are, you're having 10 new newborns a day, you're like, oh my God, we got rid of 1 billion clicks or something. So these things can make real changes. And again, it's how much of this do we control? And I think also the health systems need to decide, hey, we actually do control this. It's okay that we get rid of this thing. I mean, never in the history of the world have any of the physicians ever seen us have to have fewer documentation requirements. Same with the nurses, same with the pharmacists. We've never oh, no, we're not gonna do it that way anymore. We're just gonna, it's always oh, just one more thing. And that's honestly probably part of the root challenge too.
I got a follow-up that sort
Yeah.
of follows that
Yeah, yeah.
that trend. Talking about AI assistance for scribing, and maybe at KP, it's not the best place, but I can envision, Hal talking back to you and saying, Graham, are you sure you didn't want to take note of one more chronic illness so we can up this to a level 3?
Yeah, exactly,
This
absolutely.
was I literally was just talking on LinkedIn about this today.
So it seems like that's where the money in AI for scribing would be to help the physician bill at the best level possible. But then at KP, do you see your notes being smaller than, say, at Stanford? Because you're less incentivized to be targeting billing?
So it's interesting, we still have, we are part of the ACA and Obamacare as well, so AP has to participate in the HCC Medicare refresh stuff too. Now, you're totally right, we don't have the same incentives to code and bill. I'm not paid by our reviews, I'm all, all of us are salaried as well. The VA, yeah, totally. But I think the medical culture is still to have as much stuff in your note, and it gets back to the medical legal stuff, which sucks, but is a real concern for people too, yeah.
I think one reflection is there's a disconnect between research and between what happens in the hospital.
Yeah.
We look for a data for a clinical problem, but then we don't look at what is the house of this clinical problem in context of a workflow. And then we figure out the problem is not actually the clinical problem, the problem is something else.
Yeah.
And I think it's how do we train to focus on health system wide issues that machine learning can be helpful to, not only the clinical problem, but it's not intuitively what we look for. We look for research data on patient data on disease to run a model or build a model.
And it's, it's challenging because the clinical example that I think of with that is the challenge, there's always something that goes wrong in the ER, right? But every single day it's something different. One day it's, oh, we actually need more nurses because the nurses, somebody called out sick. Sometimes it's there's too many patients and we actually need more doctors because we just need to, sometimes we're out of beds. Sometimes we're out of supplies. Sometimes we're oh, we have a room, but we don't have a gurney that we can do a pelvic exam on. So every single day, sometimes it's the CT tech called out sick. And so now there's only one person doing CTs or ultrasound's not available. So that's the other challenge is every day it's a different problem. And so you solve the nurse thing, you hire 5 more nurses and then, oh, okay, well, there's still 7 more things that can go wrong.
We'll keep the discussion going inside, but there are a couple people online who have some thoughts, question, want to squeeze them in before we hit the
Yeah,
hour.
of course.
Steve Goodman, you want to ask your question?
Sure, you could ask it for me. And apologies, I missed the beginning if you address this. But what if the AI provides wrong information that the MD acts on? Who is liable? How do you prevent that? And who is liable?
Oh, well, I'm sure, everyone in this room will just make sure the AI is never wrong and then we're good. I think what I think will probably need to happen is there will, there will need to be at least some transition period where we've got models that are not black boxes that explain their thinking so that the doctor can see if they agree with it or not. I don't think that's at all solved or figured out. And there's like 4 permutations, right? It's like where the doctor can be like, there can be a bad outcome, right? It can be, oh, the doctor didn't believe the AI and the AI was right, but the AI was wrong, but the doctor listened to the wrong AI. I mean, there's all these different false positives and false negatives there. And I don't think there's a right answer. I think we're all literally figuring this out as we go. You know, we have a bunch of scores on MDCalc, which is kind of the current state of the art, but a lot of those are 20 or 30 years old as well. I mean, I made them back when I met Jonathan when we were in med school residency. So that's, but those are the standard of care to some degree, some of them are. But I don't think we know yet what's gonna happen. And, you know, I've said for a long time, like if the tech companies want to deploy their AI and have the same medical legal risk as all of us, great, come up to the plate, but I don't get the sense that they're as they don't have that much belief in their models as they say they do.
Let me squeeze more people in online and we can continue the in-person conversation
Yeah,
if that's okay. Then I was curious, do you want to jump in a question? I think it's the bottom question, I think it's like the adoption curve. When should somebody, I think a lot of people jumped into ambient scribes and automated responses probably actually too fast. We're so desperate for help, we just begged for something and it really wasn't ready. Well, others are trying to make a call. Should I now or should I wait? And then I'll ask your more complete question. Go ahead.
Yeah, so hi, Graham. Yeah, the old concept of doing a pilot of a solution, right, is it is not work anymore, right? I mean, traditionally the vendors will install, will do some training, will walk away, and then you try to catch them up on a phone call. So with AI now, I was wondering if is there any framework that either you have developed or you know that one that exists to just pilot AI solutions?
I certainly not developed anything. There are a couple companies that are trying to rate and evaluate technology solutions in healthcare. You know, a lot of them are going specifically on AI. There's one called Elion, ELION, that is trying to kind of rate some of these. I have some friends who I know are trying to build some environments where these can be tested as well, because just to your point, it is it's going to be a growing problem.
We want just 1 minute for the hour. Was there anything else you wanted to cover or?
No, there's plenty of, I mean, there's plenty of other challenges. I mean, money, regulations, EHR integrations, you know, obviously you can deploy a lot of this stuff as like a little thin ChatGPT wrapper really quickly with a web browser and a Chrome extension or something like that. And deploy it really quickly, but then, you know, inevitably, invariably, somebody's going to ask for it to be integrated with Epic or Cerner or any other system, which is going to take time and a lot more money as well. So that, I mean, that's the trade-off too.
Squeeze in a couple more questions. They had a theme on, other than scribes, what do you, others are AI applications seem like they actually are taking off, and how do you prioritize them? There are probably 100, actually probably there's 1,000 bad ideas, but actually probably are good ideas.
Yeah.
How do you prioritize to recognize what are the good ones to come next?
Yeah, the other challenge is, you know, like even if we had, you know, a prior authorization bot, well, it's going to be the war of the bots. The health insurers, the payers are going to build their own bots, and they're just going to be arguing with each other. And I don't know how that's decided. I do think I do think there's a lot of space for kind of some of the more agentic stuff where you could have some tools that like fill out a work note. Does the human being need to fill out a work note for every single patient? Now, like, we can't have a bot that can give somebody 3 years off and my name is appended to that I signed it, but like we could create some rules that say, oh, for this type of illness, you're allowed to give this many days off. So much stuff is under my license, which is, I think, the other part of the problem as well, that like, you know, the doctor wants to be the human in the loop because it's like my freaking license that you're signing this thing under. So I think that's the other thing is like, can we have some regulatory changes that allows maybe a health system to not just an individual human being, but like with guardrails, that the health system could sign off on that too. I don't know.
Trench legacy. Fantastic. I'm gonna close out the online session. We have more thoughts and questions. I hope people maybe could reach out to you. They can certainly find you online on social media. Very
You can
active.
find me, just type my name in, yeah.
I encourage you to follow Graham online. He's got a lot more to discuss. So I'll clear the online session. I want to give him a hand and people in person would like to.